Thank you, everyone, for attending this fireside chat. I'm very grateful that everybody is here. Um, my name is Chuza Moon. I'm an associate professor at College of Nursing at the University of Iowa. As a member of the Education Committee at the National Center for Gerontological Nursing Excellence, I'm very honored to have our second NHCGNE Fireside Chat. This Fireside Chat series is a free monthly series brought to you by the Education Committee. And these sessions will feature distinguished educators in gerontological nursing and other experts sharing insights on key topics in gerontological nursing. Each chat begins with a brief presentation followed by an informal discussion where you can engage directly with the speakers. Today, we have Dr. Kari Lane, who will talk about creating a geriatric competency assessment for pre-licensure nursing students. To briefly give you an idea who Dr. Lane is, she is an accomplished nurse educator, researcher, and practitioner specializing in gerontology and innovative healthcare solutions for older adults. With a PhD in nursing and aging from the University of Iowa, her distinguished academic career includes serving as an associate professor at the University of Missouri Sinclair School of Nursing. Dr. Lane has secured substantial research funding, spearheading projects on aging, long-term care, and advanced sensor technologies for health monitoring. A prolific author, she has contributed to leading journals and co-authored award-winning books. Her expertise in teaching that brought the extensive teaching portfolio spans undergraduate, master's, and doctoral levels, emphasizing ethics, gerontology, and research methods. She's an active member of professional organizations, and Dr. Lane was a Claire M. Fagan Scholar and 2023 National Hartford Center for Gerontological Excellence Distinguished Gerontological Educator and contributed to community-focused initiatives. She continues to inspire advancements in gerontological nursing through her research, teaching, and advocacy. In next 15 minutes, Dr. Lane will give us a presentation today. Dr. Lane, you can
Thank you so much for that kind introduction. As you have noted, today's talk is going to be about creating a geriatric competency assessment, and this was done for pre-licensure nursing students. I have no conflicts of interest to share today. I think most importantly, we understand as geriatric nurses that the global aging population is growing rapidly. Competency assessment in geriatrics is really crucial for today's healthcare landscape because geriatric care is very complex and multifaceted. So an assessment is designed to evaluate multiple areas of health, and we want to identify potential problems early, especially things like confusion, falls, or incontinence. We are also seeing that there are more and more RNs and APRNs that are being hired in long-term care facilities than we have ever seen in the past. And it's essential that our pre-licensure students can at least be minimally competent in geriatric assessments. Now, a competency assessment is not a full head-to-toe assessment. It's really about pulling together the components of the clinical judgment model and being able to think clearly from a clinical perspective about what we should do next. So for this particular assignment, the objectives are listed here. Now, I did use the NCSBN clinical judgment measurement model, and you'll note that when we talk about our presentation that I really only cover the first 3 to 4 components of the judgment model. And that's primarily because I'm using a case study method instead of a actual patient, where the student who is taking care of an actual patient may be able to better engage some of the action and evaluation components of the clinical judgment model. The clinical judgment model's first 4 steps are to recognize cues or determine what matters the most. Step 2 is to analyze those cues. In other words, what do those cues mean? Step 3 is to prioritize hypotheses or determine where they should start. And then step 4 is to generate solutions. What can I do about these things? I would mention that for the students at the University of Missouri, currently the geriatric class is the 2nd clinical semester in the program. However, they have undergone a curriculum revision, as probably most of you have done as well, and they're moving it to the final semester of the clinical coursework. So I think that will be a better position for the complexity of our patients and residents in geriatric care. So to describe what this assessment looks like, basically it's broken into 3 major sections. The students have 3 tries to complete each section. So they submit their section 1 and they get that graded and evaluated. They need to receive at least 80% or higher on that section before they can move forward. 3 times for that section, they get feedback so they know how they can improve, but not such specific feedback that they know exactly what they need to write down. Each section is cumulative, so they need to use the material that they gathered and collected in section 1 to move on to section 2 and then finally to section 3. I think it's also important to really be very clear on the course syllabi that a competency assessment is a skill, like a skill assessment. So they do have 3 attempts. They do need to score 80% or higher. But those who score less than that by the end of the term will repeat the entire class the next semester. No points are awarded for this assessment component because it basically is, have I garnered the minimum amount of skills necessary to move forward from this point? So for step 1 in the clinical judgment model, first they are given an in-depth case study that reviews all components of the patient or resident, and we use either patients or residents depending on where we're at in the content for that semester, and we'll use the same resident for all 3 parts. However, we have different cases. So there are 5 different cases, and that way there's, yes, there's some students who are going to get case 2, and several of them will have case 2, but not everyone's going to get case 2, for example. And then in the next semester, we switch it up and we have different cases. And we rotate those every 3 semesters so that there's a mix. And if a student does have to repeat the course the following semester, they will receive a different case. So initially, when they get asked questions, they are asked first, what are your top 5 prioritized nursing problems, with the cues to support them. And we do that to try to get them starting out right ahead. What's happening with this individual and what data supports that information. And then we also ask about the meaning of that data. And then we ask them to choose one medical diagnosis and describe the pathophysiology in detail. Now, we give them some choices. They could do a concept map, a narrative description, or even a detailed drawing. And that allows students to provide some initial thoughts about what's happening with that patient or resident, and also hopefully some background to connect some of the pieces later on in the next sections. So this is what they do initially. They submit that, they get feedback, and I'll talk about outcomes in a little bit. For part 2, this aligns with step 1 and step 2 in the clinical judgment model, and they're given medications, 10 medications. We try to limit the medications because otherwise they could have 40 or 50. And they're asked to complete the Beers criteria for this, for each medication. What's the medication for, or why are they taking the medication? And what's the mechanism of action? I find that many students skip the mechanism of action or think it's the same thing as what the medication is for. So that's an area where definitely students need to be thorough and complete on, and can cause them to need to go back and do more. And then we talk about or ask which medications are on the Beers list and why. And we ask them to include every medication that's on the Beers list of the medications that were listed. Then we want them to think about, are there any that should be discontinued or changed to a different medication, and provide the rationale for that. A continuation of part 2, still looking at steps 1 and 2. We're looking at additional concerns about the resident's medications, not just what's on the Beers list, but what about the other medications? What is concerning to you? We asked them to review laboratory information in comparison to the patient or resident's history and physical assessment and medication findings. And then calculate the creatinine clearance. And we asked them to do that using a formula that I provide for them that adjusts for gender. And then we ask if there are any concerns that they have for this patient based on the creatinine clearance value. And then step 3 pulls in steps 1, 2, and 3, and a little bit of step 4, but not a thorough step 4 component of the clinical judgment model. So based on the top 5 nursing problems in part 1, we asked them to list the top 2 interventions for each problem and a rationale for why. And they should relate. So they shouldn't give me a rationale for a different problem. And it should also be, the intervention should be related to the patient and supported by the assessment, lab results, etc. Then we ask them to also look at psychosocial nursing problems. And so those should be in addition to the top 5 problems, and do the same. And then they need to really think about 5 possible complications that they should anticipate. So the complications could be with anything that they've done so far. All right, so our outcomes, first of all, because this is case study based and not live patient or resident based, it is a little harder to move through the process of clinical judgment, but we did see successful outcomes. I saw that 70% of students were successful with their first attempt, and then 90% were successful with their second, and all students were successful by the third. Generally, what I saw is about of the individuals who were not successful, most of them had issues with not being thorough or complete, or not linking data from step 1, step 2, or step 3. And so when we talked through them with those results, they were able to go back and pull that information through, and then they were much more or were successful. Some of the students, just a very small number, were very concerned that they weren't successful on the first attempt. But I would say that typically those students are students who probably didn't have to do a lot of studying in the past. And so they weren't prepared to put in the work that it took. Even for each small part of this, it takes quite a bit of work and time to do the assessment accurately. Oops, lost my mouse. Comments from the students were positive. We had one student who was just thrilled to be able to put all the pieces together, things that they learned last semester and this semester. We started this competency assessment about halfway through the semester because there were things that they needed to learn beforehand. For example, they already had a module on medications and the Beers list. They'd already had a module on geropharmacology and also on the physiology and pathophysiology for older adults. And so I feel like the student comments were helpful. We did receive some comments that helped us prepare for the next session. I think for faculty, the biggest thing that was difficult was it's a lot to grade, and it can be quite time consuming to grade and make sure that the student is linking everything across each of the separate parts. However, the clinical judgment model was extremely useful to use, and it really put us in a different frame of mind for what a student could accomplish in a non-clinical course, which, by the way, they've moved the course back to the clinical setting now, which is a good move. And then it definitely furthered the students' thought processes about assessing a patient or resident. I do think it's really important to objectively note on the syllabi criteria for a successful assessment and implications of an unsuccessful assessment, so that you could go back and say, this is exactly, we're following the procedures that we outlined in the beginning. So it's very clear. And that is my presentation. If you want to see references, you can see those by taking a little snippet of that QR code, and my contact information is there as well, if you would like that. And then I have a slide for our next fireside chat, but I'll give you just a moment to take a snippet of the QR code if you would like. Are there any questions?
Well, people
Go ahead.
having their questions. I do have one. Dr. Lane, how long have you been implementing this assessment model?
Certainly, that's a great question. So we started implementing this assessment model in 2015. That is when the curriculum committee decided to pull clinical out of the Gero course for our program. And then shortly after COVID ended, we put clinical back into the program, and we're still using it today.
And Can you share any like challenges throughout, other than
Um,
a lot of
yes,
great?
certainly. So the challenges are, the time commitment that students may not anticipate. They might think that this type of a assignment coming from the classroom is like a classroom assessment, um, and it's more like a clinical type of an activity or assessment. And so I think the time component, both from the student standpoint and from the faculty standpoint, were both fairly significant. We did break the assessment into three parts after the first two run throughs because we're like, it's just too impossible to do all in one setting, both for faculty and students. And then so Jacqueline, thank you for your question. Did you create cases or use cases from clinical? We created cases based on cases that we had experienced in clinical settings. And so we used some things from our experience. We made sure there were at least 3 medicines from the Beers criteria on each list, for example. We made sure that there were a variety of medical diagnoses that had at least one that would interact with another diagnosis that could cause some type of alteration, and also a medication, at least 2 medications that would interact with each other, and 2 medications that were duplicates, so that hopefully they would pick that out as well. And Nicole asked if this was a take-home assignment. Yes, it was a take-home assignment. And they were encouraged to start it early and not do it the week of, the week it was due, that they should spend some time on it and work through all the components.
And then
You're
we
welcome.
hands up. Debbie, would you like to ask any questions to?
Yeah. First of all, Dr. Lane, just by way of introduction, I've been a licensed registered nurse in long-term care for many, many years, and I am thrilled to hear about this type of an approach to gerontological nursing. My question for you, and I don't know how long this has been going on, but do you find that it's creating an interest in the students to consider gerontological nursing settings? Because that's really where a lot of my effort is placed, is this issue of not having a wonderful image of gerontological nursing and therefore attracting people to the needed positions in long-term care. What kind of impact are you seeing from this approach?
That's a really good question. Thank you. So we may have a couple more students a year. We probably have 175 students a year that are admitted to our program. And we would get one person every now and again that would be interested in going into gerontological nursing. And now we have, 2, maybe an occasional 3. Usually, though, those are individuals who are already working in long-term care before they started going to nursing school. And I think that that is one of the things that does seem to impact students' desire to stay in gerontological nursing if they had a good experience in long-term care beforehand. However, we also have a aging in place facility that while years ago the School of Nursing ran. It's called Tiger Place. We don't run it anymore. They are doing their care on their own now, but we still do research there. And so we take students through to show them how we do research in long-term care and all the different types of research. And then we are also engaging nurse practitioners to consider going into long-term care. And Dr. Marilyn Rance has had significant grant funding to in St. Louis to implement APRNs in long-term care, and that program is working well too. Well, I think it's a multi-pronged problem, and while we might have a little bit more students who end up going into long-term care, I think that that we need more places where we can let them see what it's like.
Yes, and it is a multifaceted issue, and sometimes it has to do with what you said, their experience. If they're in an organization that is not mindful of culture and supporting them, and doing the right things and giving quality care, nurses will walk away from that. Absolutely.
Right, absolutely. Vida, you wanted to know what type of facility is used for clinical. They use both long-term care and hospital settings. For long-term care settings, students go to rehabilitation facilities and traditional long-term care facilities, and then they spend time on the Gero ward in the hospital setting. But we want all of our students to go through Tiger Place and at least step foot in the door and see what that's like as well.
And one last question. At what point in their nursing education is this taking place? Is it towards the end, middle?
So when I started this assessment, it was the second semester. However, as we implement our new curriculum revision, this will be happening in the 8th semester or their final semester, because the complexity of residents and patients is so high. We felt we needed to move it to a different semester.
Yeah, I would agree. Thank you so much for this work that you're doing, and thank you for answering my questions.
No problem. Thank you.
This has been amazing. Anyone else want to ask any questions? Or comment? I like if nobody asks, Dr. Lane, is this somewhat of a team effort, or were you like leading all these processes?
Oh, this is a team effort. It is very time consuming to create good cases, as you know. And so we had a team of 3 to 4 that worked on them, and made sure that we were able to use some real life examples and make sure that the cases were fairly equitable across the board, so that someone didn't get something really easy and someone else got something really, really difficult.
You mentioned there are 5 cases total, so maybe your team must have put a lot of effort on creating this complex cases.
Yeah, it was definitely a team effort. They're great. My team has we've got a lot of strong Gero faculty on campus, and a lot of interest. So they were willing. It just took a lot of time.
Like you mentioned, like first, like some of the students pass at the first try, and then some of the student pass at the second try. So like it was it like 25% that you mentioned that pass at the first try? Is that right?
So 70% passed the first time, and then 90% of the 30 that were left passed on the second try, and then there was only like 1 or 2 that needed a third try. So it really whittled it down pretty quickly. And I would say a good portion of the people who didn't pass the first time just didn't take it seriously or put enough time in it.
Yeah, it must be All right. You guys have any other questions? Like, if you have any questions, you can email me, or Dr. Lane also made her email available, so you can email her directly. If you guys have time, please, I put the link in the chat box. I'm doing it again. If you can provide any feedbacks to us for our fireside chat, that will be great for us to review. And otherwise, you guys have all good night. Thank you so much for coming this evening and asking so thought-provoking questions. And most of all, Dr. Lane, this was an amazing presentation. I want to implement this strategy in my school for my students as well. So thank you so much. And I hope to see you in the future too. And I hope
Okay.
everybody in the future.
Uh-huh.
The next
Bye-bye.
ad is scheduled next month. So please stay tuned.